Welcome. Ready?
Are we good?
Okay, they're ready.
Okay. Good afternoon. My name is Janie Gordon, and I'm the Program Administrator for the Mid-Atlantic Public Health Training Center. I'd like to welcome you all here today to our grand rounds on healthcare needs of homeless populations in a health reform world. Before I introduce today's speakers, I have a few announcements. For people who are watching online, please check out our archived grand rounds and other online trainings. I'd also like to draw your attention to some of our live face-to-face trainings that are coming up, including social marketing on February 7th, effective writing for public health complaints, February 21st, and cultural competency for managers, February 27th. Our next grand rounds on February 20th will be about gun violence prevention and the National Violent Death Reporting System. For those watching online, please know that you can email a question for either or both of today's presenters by simply clicking on the link. We also do ask that you fill in the sign-in form so that we can give our federal funders a better idea of who is watching and how many people are watching today's webcast. With that, I'm going to go ahead and introduce our speakers today, and we're thrilled to have Kevin Lindamood and Barbara DiPietro with us. Both are from Healthcare for the Homeless. Kevin Lindamood, the fourth Chief Executive Officer of Healthcare for the Homeless, is a local and national leader on homelessness and health. He joined Healthcare for the Homeless 2 decades ago as a volunteer outreach worker and later served as a case manager, health policy organizer, community relations coordinator, director of public affairs, and vice president for external affairs. He chairs the state's Maryland Medicaid Advisory Committee and serves on the boards of directors of the Mid-Atlantic Association of Community Health Centers, the Maryland Citizens Health Initiative, and the National Healthcare for the Homeless Council. Kevin previously taught health policy at the University of Maryland School of Social Work and speaks frequently throughout the community. He holds an MSW from the University of Michigan and a BS in Philosophy and Humanities from Valparaiso University, and I hope I got that right. Valparaiso University. Our second speaker, Barbara DiPietro, PhD, has been working in public policy for 15 years, many of them specifically focused on healthcare and homelessness. She holds a master's degree in policy sciences and a doctorate in public policy, both from the University of Maryland, Baltimore County. Her dissertation research focused on the impact of homelessness on emergency departments in Baltimore City, and she continues to work to ensure that healthcare systems can better serve vulnerable populations. She has nearly 10 years' experience working for the state of Maryland, where she helped develop the 10-year plan to end homelessness and coordinated public health policy and legislation. At this time, she holds 2 positions, one as policy director to the National Healthcare for the Homeless Council, and the other as policy director for Healthcare for the Homeless of Maryland. In these dual roles, she is able to focus on national, state, and local health policy, particularly to ensure that implementation of the Affordable Health Care Act can accommodate the specific needs of homeless populations. So we'll get started, and I believe that Kevin is beginning. Thank you.
Thank you, Janie. Thank you for the opportunity to be here, and hello to all of you watching online. Let's begin with this photograph, and I'll share a few observations that we've developed over the past 27 years and that are well documented by practice and public health research. Imagine living in a place like this, first of all. But place matters. Place matters. Homelessness is hazardous to your health, and housing is health care. Imagine taking care of basic daily human needs when you're living in a tent, and this in fact is where Tony was living, one of the clients at Healthcare for the Homeless. Tony passed away this past year, although he was not homeless when he died. He had moved into his own place. He had realized his dream of traveling across the country and moving to Las Vegas. He dropped just an incredible amount of weight. He was stabilized on his diabetes, was completely stabilized, his health improved, all because he was no longer living in this tent and he was living in his own place. Just an overview of what we're going to cover today, Barbara DiPietro and myself. We'll talk a bit about homelessness, particularly the relationship between homelessness and health, and the model of care that not only Healthcare for the Homeless here in Maryland, but Healthcare for the Homeless projects all over the country have developed to meet the unique needs and life circumstances of people experiencing homelessness. Then we will transition into a second part where we look specifically at the Affordable Care Act from a homelessness perspective. What is it that health reform might mean for populations experiencing homelessness? First question, of course, is, well, how many people in the United States are experiencing it? And that's a really tough question to answer. It all depends how you count it, and it all depends what your definition is. In the United States, it may not surprise you that we have at least 3 competing definitions of homelessness. If one uses the HUD definition, Housing and Urban Development, it's a relatively narrow definition, mostly including only people that are literally on the streets in shelter. If you look at the definition used by Health and Human Services that Healthcare for the Homeless operates, it also includes people who are doubled up, living transiently from place to place. Which frankly is exactly how people experience homelessness. If you're having trouble making ends meet, you might depend upon your network, move in with family or friends. The Department of Education also has a very broad definition in order to identify children within the school system that are experiencing homelessness. What we have here are a series of data points. And you can see who's doing the counting there underneath and what they found. On a single night in January 2012, 633,000, little more, people experiencing homelessness nationally. This is how many people were physically counted by communities that went out and did a point-in-time survey. If you look at the annual prevalence of those served in emergency and transitional housing programs that are funded through HUD, 1.5 million in a year experiencing homelessness. If you look at children, it's been estimated that 1 in 50 children nationally experience homelessness. At health centers, a little over 1 million patients identified as experiencing homelessness served nationally by community health centers. And more than 1 million students identified in K through 12 education. These are snapshots, and these are undercounts, troubled by the limitations of point-in-time data and service data. A researcher named Bruce Link back in 1990 did a different kind of survey. And he actually discovered that the lifetime prevalence of homelessness in the United States is about 7% of Americans. 7% of Americans experienced homelessness in their lifetime. 14% of Americans, if you include that broader definition of doubling up, living with friends and neighbors. If you look at a 5-year period even, 3% of Americans in a 5-year period will experience homelessness. Far higher than these numbers might suggest. And you might ask the next question, well, how did Bruce Link do this research in 1990? It was a telephonic survey. Randomly dialing telephone numbers, right. So there was a chuckle in the audience, which suggests that too might very well be an overcount when working with people that may not have ready access to phones. Suffice it to say that homelessness is prevalent in the United States and is only showing signs of increasing. This is, again, HUD data, one night in January 2012. Looking at the number of people experiencing homelessness on that night in Maryland and in Baltimore City. Baltimore City did a count last in 2011, and it was 4,088 different people. We're preparing to do our next count at the end of this month. Those in the Baltimore area may hear of a week-long series of events that's going to take place at the end of January and into early February. You can look here at the number of people identified as severely mentally ill, chronically homeless, veterans, people who have HIV/AIDS, people who were homeless due to domestic violence. Homelessness in Maryland shelters. This is the last data available from 2009. Look especially at the number of turnaways. So these are documented turnaways by Maryland shelters, more than 20,000. More than 20,000 is also significant when you look at shelter, the length of stay in a shelter and the length of stay at transitional housing. Look at the increase there, moving from 28 days to 48 days, 127 days to 162 days. So not only are more people experiencing homelessness, but they tend to stay in shelters for greater periods of time, primarily because there's no access on the other end, access to affordable housing, and we'll talk more about that. What are the causes of homelessness? Why do people experience it? And when we talk about causes of homelessness, there are certainly individual factors, and then there are structural factors. The individual factors are many and varied, and these are just a few of them. Abuse, family instability, domestic violence, foreclosure, unemployment, a range of health-related problems, medical and behavioral, incarceration, fire and disaster. Bankruptcy is a leading cause of it. But then when we look at the fundamental structural factors, homelessness is primarily rooted in poverty and extreme poverty, and related especially to the lack of affordable housing. The United States spends approximately 40% of what it spent in 1979 on affordable housing. Let me say that again. The United States spends approximately 40%, adjusting for inflation, of what it spent in 1979 on affordable housing. A broad structural problem that has only fueled the increase in homelessness. Lack of adequate access to health care, a leading cause. We'll talk about this in a future slide, but roughly 70% of people experiencing homelessness, that number's going down a little bit, but that's been the trend nationally. 70% are uninsured. Not because they're eligible but not enrolled in programs like Medicaid, but primarily because they are not eligible for programs like Medicaid. Health reform, and specifically Medicaid expansion, is going to change that dramatically, and Dr. DiPietro will talk to us more about that later. And then thirdly, lack of livable incomes. The minimum wage, as is well known, pays less, adjusting for inflation, in many cases than it did 30 years ago. At the federally mandated minimum wage of $7.25 an hour, a family working the minimum wage cannot afford a two-bedroom apartment anywhere in the country. Anywhere in the country. So housing in the private market is out of reach for very low income and vulnerable people. The amount that we spend on subsidized housing has declined dramatically, and so many people are left with no options at all. Healthcare for the Homeless did a recent survey and found that 20% of respondents in this survey were working and were living in homeless shelters because their incomes were too low. Almost 30 years ago now, there was a physician working in New York City, Dr. Philip Brickner. He was at St. Vincent Hospital, and he discovered that there were people coming into the hospital emergency room that literally were carrying everything they owned with them, carrying everything on their backs. He convinced his administration to let him establish a clinic, a primary healthcare clinic, to begin providing healthcare needs to these folks that appeared to have absolutely no place to go. The head of the Robert Wood Johnson Foundation at the time was visiting New York, alarmed by the number of people that were experiencing homelessness. Remember, this is back in the early 80s when homelessness was not as prevalent as it was today. There began a series of conversations, and a national research demonstration grant came of it, the Healthcare for the Homeless program, funded in 1985, 19 communities throughout the country. Baltimore City was one of them. At the end of that 3-year period, these were the grand lessons. which now it makes one wonder why we needed so much research to document these, but nonetheless, this is the result of that research demonstration project. Homelessness causes health problems. If you are experiencing homelessness, you're likely to get sick. It exacerbates existing illnesses. If you're already sick, you're likely to get sicker, and it seriously complicates treatment and continuity of care. Where do you keep your medications if you're insulin dependent and have to refrigerate them and you don't have a place to stay? It's also, we know, a risk factor for early death. And it's such that homelessness is really the equivalent of an additional diagnosis in the healthcare setting. And in fact, it is an additional diagnosis. The ICD-9 code, V60 right there, is for lack of stable housing. I'm told by Barbara DiPietro that it's entirely underutilized. So those of you that do research involved in coding, encourage people to make use of this code. It's actually in the the Diagnostic Statistical Manual, or ICD-9 code rather. Homelessness limits adherence. What do I mean by that? Adherence in traditional medical care or behavioral health care. Medications could be lost or stolen. You don't have a watch, don't have a calendar to write things down, don't have that little bulletin board to put your appointment there, or an iPhone or iPad these days to put it in. No routine supplies, copays unavailable, meals unavailable, or really on someone else's schedule. Most of the people served by Healthcare for the Homeless get their one meal of the day at Our Daily Bread, which is the city's largest soup kitchen, certain time of day, and that might be their primary source of food. Some treatments risk arrest in the community. So if someone's on a diuretic and doesn't have a regular place to go, quite literally, there are not an abundance of easily accessible public restrooms in Baltimore City or in many communities, and many of the folks that we work with end up getting arrested and incarcerated because they were adhering to the medications that we prescribed. Generally, people experiencing homelessness suffer the same range of health problems that the rest of us do, only at extremely higher rates. That said, here are some common diagnoses that health providers see when working with this population. Infectious disease, hepatitis, HIV, TB, far higher in homeless populations. Chronic disease, diabetes, asthma, hypertension, heart disease are the big ones. Parasitic skin infections. Our previous medical director, Danielle Robertshaw, was a fan of lice and scabies and did much to educate the staff at Healthcare for the Homeless and shelter providers in the community as well. Dermatologic conditions, skin conditions, weather-related problems. Trench foot is not just for war veterans any longer. Trench foot is seen in communities all over the United States when people live under bridges and on park benches. Chronic pain, poor dental health. Medicaid in Maryland and in most states does not cover adult dental care. So as you might imagine, dental health can deteriorate relatively rapidly when you don't have a regular place to go for preventive care and don't have any access to restorative care. Let's talk a bit about infectious disease. I mentioned that the rates were higher. The prevalence of HIV in homeless populations compared to general populations in the United States, 3.4% in the homeless population, and still less than 1% in the United States. That's striking. Some areas of the community, of the country, including Baltimore, it's far higher, primarily because Baltimore still remains the heroin capital of the Milky Way, and IV drug use is common. Hepatitis C. One homeless veteran study found a prevalence of 44% of Hep C. This is striking. In Baltimore, 26% of the people we served had HCV listed in their top 3 ICD-9 codes in 2009. Troubled by that, we decided to test further. We follow the CDC guidelines and do universal testing, and closer to 45% of adults are positive for chronic HCV. That's striking. And the consequences of that, I think, we're still working through. Behavioral health conditions. Rates really depend on the population being screened, and it depends upon whose definition or whose data you're looking at. Generally, according to HUD data, Housing and Urban Development, about 18% have a serious mental illness, 21% a chronic substance abuse issue, and 50% of folks with mental illness also have a substance abuse disorder, according to HUD data. The Healthcare for the Homeless experience and our data suggest that it's even higher. About a third of those served by Healthcare for the Homeless in Maryland, and this is similar to Healthcare for the Homeless projects nationally, has a major Axis 1 mental health diagnosis: schizophrenia, bipolar, major clinical depression. 25% of the people that we saw last year were duly diagnosed with both addiction and mental health, and that's a troubling couple of conditions to treat. Of course, there's a lot of data that this is along the lines of homelessness being hazardous to your health, about morbidity and mortality in homeless adults. The average age of death among people experiencing homelessness between 42 and 52 years of age, right? Despite the average life expectancy of about 80 years in the United States. Homeless persons less than 50 years old have the health of 70-year-olds but do not qualify for Medicare. I like that bullet. Thank you, Barbara. The first study comes from Dr. Jim O'Connell, who is a Healthcare for the Homeless leader and a researcher up in Boston, who's done much work on mortality in homeless populations. The last bullet here, an average of 8 to 9 concurrent medical illnesses, comes from Dr. William Brakey, a retired psychiatrist at Hopkins who still serves on the board of directors of Healthcare for the Homeless. He was a founding board member of ours 25 years ago, and did a lot of the early work on homelessness and health and homelessness and mental illness. There's a growth in the number of kids experiencing homelessness. So whereas in the early days of Healthcare for the Homeless, we were primarily seeing single adults and specifically single adult men, we're seeing these days more women. A third of the people we saw in our organization last year were women, and seeing more and more children. In Maryland, the population of school children, in schools, the population identified as homeless doubled recently. There's been a lot of news coverage about this, not just unique to Maryland. It's happening all over the country as well, particularly in this economy. Greater than twice as likely as children who are middle class to have moderate to severe or acute and chronic health problems. So again, homelessness leads to health problems and exacerbates existing illnesses, has a negative impact upon school performance, obviously, and leads to increased rates of fill in the blank. There's a partial list. As I mentioned previously, people experiencing homelessness generally are underinsured or uninsured. This is Healthcare for the Homeless Maryland data of the little more than 9,000 different people we saw last year, and there's a big asterisk by the uninsured number there at 50%, but let's go with that for a moment. 50% uninsured, about 20% Medicaid, about 5% Medicare. So about 25% Medicaid or Medicare. That additional 25% there, any ideas what that is? That is the Primary Adult Care Program, which is a relative of our state's previous indigent care program, which today is folded into Medicaid. The state gets a federal match for it, but it's a Medicaid light program. It's primary care only. It's not true insurance. And in fact, this comes from HRSA's UDS, the Unified Data Set. We're being told this year, last year we were told we had to count it as insurance in another category. This year we're told that that is not insurance and we're to put it back into uninsured. So if you put those two together, 75% of our clients lack comprehensive health insurance. That's what's going to change dramatically. Let's look at the national picture. 62% uninsured, 28% Medicaid, 5% Medicare. and then some private insurance and some other. Health reform and Medicaid expansion to 138% of all adults, regardless of category, will capture a large percentage of the people that we're serving. We believe that within a couple short years, 80 to 90% of the people we're serving will be insured. And Barbara will talk much more about that. So homelessness is an ongoing problem. It's the result of very intentional public policy decisions in areas of housing, healthcare, and incomes, starting in the 1970s, in the late 1970s, and continuing today. A dramatic disinvestment in housing, especially public and rental housing. Cost of living has increased faster than paychecks. Evictions are up. Unemployment is high, especially among low-income groups. Deinstitutionalization created street homelessness among those with serious and persistent chronic mental illnesses. At the time, in the late 70s and early 80s, when the country was trying to wrestle with the growth in homelessness, why are people experiencing it, deinstitutionalization was cited again and again and again as the number one driver. What we're realizing now in retrospect is that it was a contributing factor. We need a better way of addressing serious mental illness. No, we shouldn't institutionalize people, but we need to care for them in different ways in the community than we're caring for them now. But it was less of a factor than some of the other factors that we now generally realize were causes of the problem, like the decline in investment of in affordable housing, for example. So the healthcare for the homeless model of care has grown since 1985. Today there are well over 213 some projects nationally that receive federal healthcare for the homeless funding from the Bureau of Primary Health Care. The services include outpatient primary care, mental health. These are our services here in Maryland and in Baltimore. It's often said if you've seen one healthcare for the homeless program, you've seen one healthcare for the homeless program. They're all designed to meet the unique needs of their communities, but they provide some essential services, the same range of services to people experiencing homelessness. We provide addiction treatment. We have a pediatric clinic, a dental clinic, really Maryland's first comprehensive dental program for homeless children and adults. We do a lot of outreach, case management, supportive housing programs. The goal is to increase stability and improve health. Our goal isn't just to ensure access to health care, but we're successful when we can stabilize somebody and house them. And then we find that their health tends to improve, which takes us back to this notion that housing is, in fact, a form of health care. A little more on the current environment. There's an increasing understanding that poverty is really the core issue. I mentioned the changing population. In the interest of time, I won't go into 10-year plans, but most communities have developed 10-year plans to end homelessness. Most of them have to do with housing, healthcare, jobs, and a strong safety net, and most of them are woefully underfunded. There are some communities that have been making great strides. Baltimore has been working a lot in the housing first model, and I'll conclude with an analysis of that. But more resources are needed, and it's extremely difficult in this environment where there is a lack of political will and an extreme stalemate on investing, social investments in the United States. Health reform has the capacity, we believe, to dramatically improve access to care and improve the health of vulnerable populations if we implement it in the right way. And if we use it as an opportunity to sustain people in permanent housing and off the streets. There's also a paradigm shift going on. For much of the past 30 years, homelessness has been treated with let's call it a housing readiness model. So someone's experiencing homelessness, the question was, well, what's wrong with them? What do we need to fix? Let's get them access to health care and mental health services, and let's move them into a transitional shelter, and then let's finally find a way to end their homelessness. What we found in that paradigm is that the poorest and sickest tended to stay on the streets. And those that could navigate various systems tended to move through them, but then people kind of got bottlenecked up in that continuum of care because there wasn't sufficient housing at the end. The model that's really being shifted to now, and right now I think there's still two competing paradigms, is one of housing first. And we generally find that if you help rehouse someone as quickly as possible without treatment as a precondition, right? Still might have a range of medical problems, still might have a mental illness, still might have an addiction, and might not be getting treatment for it. But if we house someone first, they tend to stay. 85% of the people that we've housed using this model stay housed and off the streets long term, our oldest program being 8 years. 85% still housed and off the streets. But their health also tends to improve. They show up less often in emergency rooms. They don't get arrested as often, if at all. This is Christopher. Christopher lived for 15 years on a park bench in War Memorial Plaza in front of Baltimore City Hall. People tried to do outreach to him. He would start screaming and chase people away. He was deemed not housing ready for every program that people helped him apply for. Not housing ready, not housing ready. Well, he never got access to the services that he needed. Christopher was one of the first people that, with this housing first approach in Baltimore, we helped and we placed him directly into housing. And guess what? He stayed. He's moved a couple of times. We've helped him move, but he's still in the program. He's connected to Care at Healthcare for the Homeless. He's connected to mental health services, connected to medical services. And in fact, this mural, which for those of you in the Baltimore area may recognize, it's on the side of the Healthcare for the Homeless building. It was created by the staff and clients of Healthcare for the Homeless. When the reporter for the Baltimore Sun was covering the unveiling, Christopher, this gentleman, was standing right next to me because he had helped create that mural. And the reporter said, "Christopher, what part did you work on?" And he pointed to the moon and stars up on the top of this mural, and he said, "I worked on those because when I was sleeping on the park bench and I looked up at night, those are the things that I saw." Christopher today is no longer homeless because we were able to house them and then give them the care that he needed. It suggests a direction for future public policy that how we deal with homelessness is to essentially treat it as a housing problem. Rehouse people as rapidly as possible, and then bring the services to bear that someone might need for a short period of time or a long period of time that keeps them stably housed and off the streets. And with that, I will introduce Dr. Barbara DiPietro, who will talk to us about the importance of health reform for vulnerable people and the opportunities we all face to implement Medicaid expansion in the right way. Barbara.
Thank you, Kevin. And so Kevin ended by talking about a paradigm change. Are we ready for a paradigm shift? And one of the things that is moving us toward that paradigm shift is the Affordable Care Act. And one of the things that I want to talk about is just some of the core provisions that are in this. There was a fantastic Grand Rounds presentation that was done in October that I want to reference by Rebecca Pierce and Carolyn Quattrocki, both with the state of Maryland, who did an overview, a very detailed overview on what the Affordable Care Act means for Maryland and the exchanges and Medicaid. But for today, I just want to focus the exchanges and Medicaid expansion. So the expansion of insurance is really where the Affordable Care Act, its primary components. There's a lot going on in that law, but these are really the major changes. Health insurance exchanges, many of you probably know, these are required at the state level. They can look a lot of different ways, state-run, federally financed, or a partnership. There's subsidies for low-income people, but essentially these are marketplaces, individual, small group market. And then this is looking at more private insurance that is in one general place where people can shop. Of additional note, though, is the Medicaid expansion. Now, this is made optional by the Supreme Court decision at the state level, and I am delighted that Maryland has been absolutely committed from day one that we were going to expand. And so Maryland has not been part of the back and forth, and maybe we will and maybe we won't. And that, I think, is a real source of pride for us. For those who are looking at the financing of that, it starts out initially fully federally financed for the first few years, and then over 6 years, it steps down to about 90% federal financing. And so one of the things that we're looking at is how this will operate nationally. But here in Maryland, this is something that we're looking forward to. 138% is about $15,000 a year for an individual. This is effective January 1. So treatment starts January 1, but open enrollment starts in October of this year. And so there's so much work to be done to really find and enroll people so that we're ready to go and provide care in January. So one of the things, I think we were going to be taking questions in the end, so I'm just, if you can hold until then. So Kevin talked about disparities in health insurance. This is what this looks like when we compare healthcare for the homeless nationally with other health center patients, other low-income, underserved populations, and then generally in the United States population. And you can see the disparities, certainly a disparity in being uninsured for homeless individuals. Again, just the folks that we're serving at HCH projects, this is nearly 500,000 folks that are uninsured. Most of these people will be eligible for Medicaid expansion come 2014 in those states that choose to expand. We know, and this is a public health audience, we know that the poorer you are, the less likely you are to have insurance. It correlates. And the wealthier you are, the more likely you are to have private insurance. It is a misnomer, and I think in the general population, in our political discourse, that just because you are poor, that you are qualified for Medicaid. We specifically have a gap in Medicaid that's been established in federal law that prohibits Medicaid coverage for single non-disabled adults without children. And this is what the Affordable Care Act is going to fix. So when you look at eligibility thresholds, now this is averages across the country, but we do nothing for childless adults. We do something for jobless parents, something for working parents. We tend to do pretty well by children and pregnant women. But again, we have no consistency. And one of the things I think that's also a misnomer is when we say the United States has a healthcare system, we don't really have a system, or if we do, it's not really a very good one. We have a patchwork of healthcare programs that don't do a very good job of coordinating with each other, and we have fragmented care, and actually when we compare ourselves to international colleagues, anyone we'd want to be compared to, our quality outcomes are not as good. So this is the gap that the Affordable Care Act fixes. So currently eligible, generally speaking, we look at children, pregnant women, people who are disabled, and then some parents. What the Affordable Care Act does is it provides at least some common threshold. So you'll see that bar here across we're at least trying to streamline. So those who are newly eligible expands to people earning up to 138% of poverty. So again, I had mentioned $15,000 a year for singles, goes up to about $25,500 for a family of 3. 15 million people, will be newly eligible again if all states expand. We know the parameters around this in terms of being a U.S. citizen or legal resident. There are a number of states that actually have already gone forward and taken the step to increase their Medicaid programs in full or in part to date, using some options in the Affordable Care Act. But Maryland, again, we're doing open enrollment in October, and we'll go live in January. The Affordable Care Act not only closes the gap in eligibility, but it also makes some real significant improvements in the enrollment process. And one of the things a number of things that we're looking at, electronic verification of income and identity. This is a big, big improvement. If you are homeless, you don't have all of your documents with you all the time. They were either stolen or lost or destroyed in the rain or what have you, but we replace birth certificates every day at Healthcare for the Homeless. You need a birth certificate. You need an identity card. And in a lot of places, you can't get into the Social Security building without an ID. But in order to get a Social Security card, you need an ID. It becomes this almost sadly comic catch-22 on how you get an identification when you have no money. So again, but the thing is that we know electronically how much people make. We know how much, all of us are in the IRS, and even proving lack of income is going to be possible. So electronic verification for our patients is going to be a particular boon, and again, they're going to be matching identity and citizenship through the Social Security Administration. So just knowing your name, your Social Security number, your date of birth is going to be enough. We can electronically verify who you are and how much you make. Using gross income, no more asset tests, no more teasing through whether you have a car, what the value of the car is, all of that. It's enough just to go on what you make. Faster approvals and turnaround times, no in-person interviews. Again, all of the kinds of barriers that traditionally have tripped up lots of populations, but in particular homeless folks. And then online applications, I mean, there will be the possibility to do by phone and mail, but we're going to really be streamlining this online. The address is also a big deal. You don't have to prove your residency with paperwork that doesn't exist. Usually we prove where we live by bringing in our mortgage, our rental statement, a utility bill, some piece of mail. But if you have no address, how do you prove that you live in Maryland? And so again, these makes enrollment improvements that will really streamline this process. It puts alternative points of contact. If I'm not reliable to get in touch with, my case manager might be. And putting her on that application really will streamline questions or anything that might come up. Again, these are traditional barriers that the law really makes much better. And when we ask, well, what is it about Medicaid that's going to be so important? Here are 12 reasons, and there's a wealth of information and documentation in the public health literature that goes behind each of these points. I didn't want this to be a full treatise on a literature review, but I think that we're pretty square, and the documentation shows that having a health insurance not only stabilizes your health, it stabilizes your finance. Medicaid has been demonstrated to be good quality care, high patient satisfaction. It's a fairly efficiently run program, not as efficient as Medicare, I might add, which also could be expanded. But when we look at Medicaid itself, these are the real reasons why this is critical for this population. When we look, however, at who is likely to enroll in Medicaid, this is where we start getting into the nitty-gritty of the implementation. And this is where we start balancing risks and opportunities. 15 million people will be newly eligible, but that's only if all states expand. And when you look at the numbers of the Congressional Budget Office, they're only estimating that 7 million people are going to enroll in the first year, and after 2 years, only 10 million people will enroll. Why is that? Well, part of the reason is this. So this map shows the disparities of where states are right now and whether they're saying that they're going to expand Medicaid, whether they might expand Medicaid, whether hell no, they're absolutely not going to expand Medicaid, or whether they just haven't committed yet. Now, this map is constantly changing. This is as of January 10th, but checking back, with advisory.com/Medicaid map will give you an updated version of this as more and more states are making final determinations. A lot of their budget processes and legislative sessions that are going on right now will be making these decisions this year. But here's another reason. Eligibility does not automatically translate into enrollment. What we know about take-up rates for people who were currently eligible for Medicaid, we're still seeing almost 7.5 million adults and children who are currently eligible for Medicaid but are not enrolled. And so again, the barriers to enrollment, the barriers to finding people. One of the things that is really an improvement, the ACA requires states to do outreach procedures to vulnerable populations. There's a whole list here. I've highlighted 4 of the populations that are particularly concentrated in the homeless population. Obviously, homeless youth is its own category, but victims of trauma and abuse, nearly all of the patients that we see have got trauma history. And so again, trauma-informed care and all of that can really be helpful in the delivery of care, but we have to start by finding people and engaging them because eligibility does not necessarily equal enrollment. So this is what we're looking at in Maryland in particular, and these are the projections that was done by the Hilltop Institute in July last year. So when we look at people who are going to be becoming newly eligible, we're talking about 90,000 people in the first year and then moving up from there. We have then, of course, people who are currently eligible but will enroll as part of the woodwork effect, right? So we're going to be doing a lot of advertising and campaigns and outreach and education. And as people are coming into that net, we'll be having 2 populations come, people who are newly eligible, people who are currently eligible. And so the current population in the Medicaid program is projected to really grow. And I think this is a good thing. Now, it certainly raises implementation and administrative challenges, but from the point of view of public health, this can only be a good thing. And so one of the things I'd really like to correct, and one of my pet peeves is when I hear news media or the commentary talking about universal health care. Everyone's going to be covered by insurance. Affordable Care Act is, in particular, socialized insurance or, This law does not establish a right to health care in America. And this law does nothing to establish universal coverage. And I think it's so important. And if I could ask one thing, please, if you hear someone using those global terms, correct them. Because this is what the reality might be. The Congressional Budget Office projections after the Supreme Court decision showed that we are going to remain in 2014 with 41 million people remaining uninsured. 2 years after this bill goes into effect and the exchanges are online and Medicaid expansion is up in states that choose to expand, we will still have 30 million people that remain uninsured in the United States. And I think that this is the story that no one is talking about. What grieves me is the political capital that we are spending, all the blood and sweat and tears that we have put into either fighting or championing the affordable health care. When it comes to solving the problem of an uninsured population, we've only got a glass half full. We have to figure out what is the next step. What is beyond the Affordable Care Act so that we can bring this clear disparity down? The statistics that you're seeing here is an Urban Institute's analysis that showed that of the remaining uninsured, we have a number of people who actually will be eligible but unenrolled. Again, what we know about take-up rates. We know that about 1 in 4 of the uninsured will be undocumented or ineligible immigrants. So thinking through, particularly from a public health standpoint, what is the provision of care for people who are not enrolled in an insurance plan? And it will be a mistake to assume that anyone who is uninsured past 2014 is automatically an undocumented person. So thinking past stereotypes and really looking to the fine-tuned piece of delivering comprehensive care to everyone who needs it is really going to be the challenge. And how do we incorporate real truth into the political discourse that we have going on right now? When we look at the change in percentages just here in Maryland, these are projections. Again, this is the Hilltop Institute in July. But again, Maryland is going to be on average with the United States in that we're reducing our rate of uninsured by half. So again, this is palpable improvement. This is absolutely a step in the right direction. But I think that we really, again, need to be thinking about this law does not solve the problems in our healthcare system, but this makes tremendous gains in addressing them. So just some quick numbers on the remaining uninsured. So when we think about extensions of insurance to particularly a very low-income population that is vulnerable, has a number of healthcare conditions that Kevin described, let's think about how do we care for that? So when I said that eligibility doesn't necessarily translate into enrollment, there's another step to that. Enrollment doesn't necessarily translate into engagement and care. And let's think about all 3 steps. We have to find people, we have to enroll them, we have to engage them in care. And it's that engagement in care is where the magic is going to happen. It does nothing of real substance to carry a Medicaid card if you have no one who's going to see you. And it does nothing to have a Medicaid card and just have that card and not go and see anyone who's going to address the multiplicity of healthcare conditions that you have. That's just enrollment. That's just a card. And at the end of the day, it'd just be a piece of plastic. We need to really think about how we're delivering care, not just to the general population, but really to some of these very acutely ill subpopulations. So how do we integrate care? Right now, Maryland is thinking about how do we integrate our mental health and behavioral health and addiction system, and thinking globally, what does this look like in a coordinated way that includes medical care? How do we focus on quality and outcomes? And really whether people get better, whether they're able to stabilize, whether their health status improves, not just the number of MRIs and the number of procedures that we did. We have to get away from that mindset. This law really tries to turn that boat into a direction of quality and outcome. But again, thinking about what does that really look like in the contractual procedures and how people are reimbursed, and really what are the incentives being built into our new healthcare system. Thinking about patient-centered medical homes, electronic health records, coordinated care. How are we tracking people from hospital to community care, across behavioral health, into inpatient care, into a variety of things, nursing homes, assisted living, step-down units. We have so many different kinds of care, venues of care, but how are we exchanging information? Oh, we may have electronic medical records in an individual provider, but that doesn't necessarily mean that that provider can speak to 10 different other places where you've been and coordinate that data. We're still going to be wrestling with how we exchange information and how we make decisions, clinical decisions and administrative decisions based on data. And then thinking about how we're coming back to the social determinants of health. When we think about the social determinants, housing is clearly present there. Kevin started off by talking about place matters and housing as healthcare. This is fundamentally built into this. So thinking not only just beyond Affordable Care Act, but let's think about beyond simple traditional definitions of what healthcare delivery is. If we are going to be insuring a sick population and that population's living on the street, let's think through what that means absent housing. You can spin somebody through an addiction recovery program that now will be covered through Medicaid, and you can do that 2, 3, 10, 15 times. If someone's being discharged to the street, if someone's still not stable afterwards, well then you've just wasted the investment of treatment 2 and 3 and 5 and 10 and 15 times, and then we wonder why people don't get better. You can spin somebody through the emergency room, and we've got tons of data on this, 185 times in a given year. My dissertation showed the top user of emergency rooms in downtown Baltimore City visited an emergency room 185 times in 1 calendar year. That is every other day. And at the end of the year, still sick, still homeless. What was the what quality of care was able to be delivered? What's the value of the services that we all contributed to? And at the end of the day, what happened to her? We can do better than this. Again, thinking beyond, what are we ready for a paradigm shift that really includes housing as part of healthcare? So one of the things that I just recommend that we think about when we go forward, particularly because this is a lot of information and a lot of slides here. I'm hoping that you've got those so that you can refer back. Use this information not only in your research, but also in your discussions, family and friends, your community leaders, and all of the conversations and forums that you're in to influence this, thinking about what do we do with this information. We have to ensure that we're targeting outreach. And outreach means a lot of different things to a lot of different people. But we have to think beyond bus ads and billboards and really think about having somebody out there who can beat the bushes. Go under bridges, into the alleyways, into the encampments to find Tony's tent and make sure that Tony's not only outreach, not only enrolled, but engaged in care. So thinking about enrollment, thinking about how we track that. We've suggested that maybe StateStat or some body really measure how are we going to ensure that those at the lowest income groups are being enrolled in Medicaid. And then track the capacity. One of the things that I'm really interested in is, and we're talking a lot about the economy and jobs and all of this in this country right now. It's the #1 issue in the last election. There is nothing about the Affordable Care Act that's not a jobs bill. That was a double negative. Let me say it the other way. The Affordable Care Act is a jobs bill. We act like this money is all going into thin air to people who people who either don't deserve it or it's curious the rationale. But at the end of the day, Medicaid payments go to doctors and nurses and medical assistants and a broad range of therapists and social workers. And it's not just the direct care and the direct workers, it's also the indirect workers. Medicaid payments that support places like healthcare for the homeless and other community health centers and a full range of doctors' offices also pay for the woman who answers the phone and the people who do the billing, and then indirectly the people who clean the building and do the wiring and fix the plumbing and come in and do the painting. All of this comes into our local communities. All of this money goes to support local jobs, local economy, local families, and I just really wish and I would urge everyone to try to insert the economic development that healthcare can be for our community. Maryland, and particularly Baltimore, of any place in the country, which has a lot of its economic development employment base rooted in healthcare, should know this. When we grow our healthcare system, we're also growing our employment base. So thinking about this in a different way. So when we talk about medical and behavioral health service capacity, who's going to be seeing these patients? Who's not only willing to see Medicaid patients, because Medicaid is also, not always the best reimburser. So we have people who are dropping out. But thinking about where are they? Have they been trained in treating poverty as an influencer and how poverty influences health and healthcare utilization? And some curious decisions that we might say, oh, you're just not adherent to medical plan. Well, could it be that this person's sleeping in a shelter or in the street? Do we think to ask? So how is the medical community really willing to serve and then understanding what their services mean? Thinking about MCOs, there's a breadth of services that are going to be needed to achieve cost savings, and that could include housing. There are a number of pilots and some questions that are being asked nationally about how MCOs can incorporate rent or incorporate housing into the plan that they might be able to target toward this high needs population. Again, if you can pay $900 of rent a month for someone who's a high utilizer and you've saved 5 emergency room visits, you've already made that back. So thinking about a broader definition of health. Thinking again about the impact of poverty on health, thinking about services for the remaining uninsured, and how we're pursuing additional insurance expansions. Again, we are not finished with the work to be done on the uninsured, so thinking beyond that. And again, thinking about the states have got a number of options. Medicaid is an incredibly flexible program. Lots of options for states to pursue, to add services, target different populations, and think about how they might be able to achieve the quality and cost outcomes they want to see. That could include Medicaid payments into supported housing. So again, thinking about that and raising those as recommendations. In moving forward and in trying to conclude, there are a number of opportunities that the Affordable Care Act offers us, and particularly this patient population, but there's also a number of risks. We have the real potential here, when we do this meaningfully, to improve individual and public health, to reduce personal bankruptcy and poverty. We have the opportunity to really stabilize people's finances. Increase individual and family stability. If there are people in the audience who are really about the child welfare situation, thinking about how many children are removed and put into out-of-home placements every year because parents struggle with behavioral health conditions. Are those parents insured? Are they engaged in care? How are we really delivering services that we can stabilize families through health care and possibly see some improvements in the child welfare system? Again, just thinking beyond and wider. Again, I come back to employment and productivity. This is certainly going to be a jobs bill, but it's also going to be asking more of the people that we employ. So how is it that we're really balancing productivity and quality of care? Thinking broadly, think about recidivism to criminal justice. If we have people who are going in and out of central booking and America's detention centers and jails every day, we have 12 million people in jails at any given time in the United States of America, many of them with significant behavioral health conditions. If we're treating people in the community, if we have a behavioral health capacity in America's communities that can handle serious mental illness and serious substance use disorders, maybe we can actually stem the tide of behaviors that lead to arrest. Maybe we can reduce recidivism for this population. And from a financial standpoint, every healthcare service that's offered behind the wall is at 100% state expense or local expense in some cases. If we're offering this in the community through an expanded Medicaid population or program, it's at 100% federal expense. States have a real incentive financially here to look at savings from their criminal justice system, particularly their health care, if we can really invest that in our communities and in behavioral health. I think this has got tremendous promise. We actually, I think, have the potential to prevent and end homelessness through better health care if we can do this right and think broadly. But if we don't do it right, and we're not thinking broadly, if we're thinking narrowly, or if we're looking to nickel dime and do that, penny wise, pound foolish kind of policy, which unfortunately characterizes a lot of our healthcare system, if we fail to reach the newly eligible, if we continue the barriers to enrollment, if we're not really investing in providers, if people have difficulty finding someone to treat them or difficulty engaging in care, then we're not going to get there. if we have ongoing housing stability, again, if you're living in a shelter or on the street, what's really the incentive to get clean? What's your ability to get clean? Living on the street's real hard, and drugs and alcohol almost make logical sense. If you are going through those kinds of crises in your immediate time, you don't have the supports when you're living on the street to be able to maintain sobriety. That is extremely difficult. So thinking about how we're turning that paradigm shift, like Kevin described, and putting people in housing to be able to address those issues. And then thinking about poor transitions. As people are getting jobs, as people are rising up, Medicaid eligibility is at about minimum wage full-time work. And if you are at $725 at 40 hours a week, that's riding that $15,000 a year line. If you get at McDonald's that nickel or that dime bump, and you're up to $7.50, $7.75, $8 an hour, you've bumped up out of Medicaid and into the exchange. There's a whole workforce here task force here in Maryland that's focused on that continuity of care. How are we transitioning people between Medicaid and the private plans and the exchange that will treat them? What does that look like? The legislative session is planned. I think we have a bill coming up that will talk specifically about how people do that transition. But thinking about that is a real opportunity. It's a risk for a gap. And people falling through the cracks, having treatment disrupted, not being able to find a doctor, and not being able to find a doctor that really understands their conditions or the other life circumstances that they bring to the table. And so we jeopardize that fragile financial upward mobility as people start getting a job and working their way up. If healthcare is going to be the linchpin there, then we risk people really losing that. And the risk, of course, then would be ongoing homelessness. Here's some more information about healthcare for the homeless in Maryland and ways to get in touch with Kevin and I. But I think this has given you an appreciation for where we're coming from caring for a vulnerable population, as well as the risks and opportunities in the law. But I think we've got a number of questions that hopefully have come in. And please put your questions online because we'll be receiving them here. And I will turn it over to Janie Gordon at this point to facilitate that discussion. Thank you.
Thank you very much. We're going to be doing this a little bit differently today. I'll be fielding questions from out here in the audience. First of all, do we have any questions from the live audience at this point? Okay.
Hi. Thank you for this articulate presentation. One of the questions I have is what you were talking about with the gray area between, right above Medicaid, the new Medicaid eligibility. So if you make above minimum wage and entering, so either if you're going up and entering the private insurance exchanges, or if somebody is employed with benefits and then loses their job. Can you talk about what that would look like and how to get people into care that way?
One of the things that I know the Task Force on Continuity of Care here in Maryland and policies nationally are looking at is if you are engaged in treatment in particular. So we don't want to disrupt treatment. So let's use the example of someone who's receiving chemotherapy. If you've been approved for chemotherapy and then you lose your job, for instance, and then you're coming into the Medicaid system, how is it that your doctor or your treatment isn't, what's your prior approval? Does the new plan have to accept that prior approval, particularly going from Medicaid into the exchanges in particular? So thinking about what those agreements look like. Who's your doctor? Do you have to change doctors? Do you have to get all of your authorizations for your medications or your treatments done over again? Is there a disruption in whether you can refill your meds? These are questions, and I think right now we have a lot of questions about what this looks like. Until it actually gets implemented, we won't know what that looks like, and I imagine it'll be all over the board. Some people will be making a very seamless transition, and then for various reasons, other people will have trouble. I think we're really trying to put in place a system that minimizes that. There will be navigators and assistants, and I think a lot of people who will try to help with this. But ultimately, a lot of that is aimed at people who are very confident in using that kind of assistance, have a high level of health literacy, And so my concern is for particularly vulnerable populations. They're going to be relying on providers like Healthcare for the Homeless and other groups to really help them navigate that. So that may be both an answer and more questions back to you. But I think that this is an area that a lot of people are focused on and how that's going to work. And this is obviously both technically difficult in the computer systems and IT systems that are being implemented to try to navigate this, as well as just the warm handoffs between providers. And I'll turn to Kevin if there's anything he wanted to add to that.
That's good.
Okay, here's a question from online. Since the tragedy at Newtown, much attention has been focused on gun-related violence. How is the homeless population affected by gun violence?
That's a great question. And after the Newtown incident, I remembered a conversation that Barbara and I had on a policy committee call of the National Healthcare for the Homeless Council, when one of our members was suggesting that Healthcare for the Homeless develop a policy on gun safety and gun violence. And certainly in some communities like Baltimore, vulnerable people certainly are exposed to high levels of gun-related violence and death. But at the time on that call, we essentially said, important issue, but it's not really directly related to homelessness in a causal way, so not necessarily something we should take a position on. The day of that incident, I remember kind of remembering instantly that conversation and being vexed by it. And since then, exploring what is the relationship between homelessness and gun violence. And though I don't think there's a causal one necessarily, they're definitely related in that both are symptoms of failed public policies. Both are allowed to exist in the United States at higher rates than in any other industrialized nation because our policies related to guns and gun safety and our policies related to housing, healthcare, and incomes and a sufficient safety net are fundamentally different in the United States than they are in other industrialized nations. So I think there's an interesting relationship between those two factors and something worth exploring further.
Hi, I wondered if you could talk to us about the initiative that the mayor is for the 75 homeless off of the street and how this relates to your concept about housing before treatment.
Yeah, it's fantastic. The 75 Journeys Home is the name. It takes place during what's called Registry Week. All of this is part of the National 100,000 Homes campaign, which is a national effort to house 100,000 of the most vulnerable people in the United States using a supportive housing or housing first kind of model. And so Baltimore is participating in this and is doing its census concurrently with this registry week, where service providers and volunteers will fan out across the city and administer what's called a vulnerability index. And this index is similar to the one that we've used now for many years to try to identify those that are most vulnerable and frankly most likely to die on the streets and then house them. There's work already happening in Baltimore City to house vulnerable people. We just got word recently that 18 individuals, vulnerable people, this month will be getting keys to their own places. And that's just people affiliated with Healthcare for the Homeless. There's more throughout the city. All of this happens, though, when limited housing vouchers are made available. These are extremely, extremely limited. When affordable housing is not available, this kind of work can't happen. So I think the 75 Journeys Home campaign here is a wonderful expression of the housing first model being so effective. It is incredibly small relative to the broader scope of the problem. But I think in terms of raising public awareness, of generating excitement around it, and frankly, housing some extremely vulnerable people, it's a very good thing, and we're proud participants in it.
If I could even tag on
Please.
to Kevin's piece too. One of the things this is a tremendous initiative, so all kudos. At the same time, we haven't changed really any underlying causes of new vulnerable people coming onto the street. Mm-hmm. And so it's in some ways, and I speak with my national hat on, this is like bailing out the bathtub but not turning off the faucet. And so I would like to see these initiatives coupled with larger access to affordable housing for people who have not yet been considered and scored so vulnerable that they're considered the 75 sickest people in Baltimore City living on the street. That's a dubious badge to carry. And so I would like to see this coupled with larger policy change to address the structural factors that Kevin outlined earlier.
And what it does to take 75 housing vouchers or 75 housing placements and direct them toward extremely vulnerable people is to take those 75 opportunities away from other people. So to Barbara's point about the bathtub and the faucet still running, the downside of this initiative is we seem to be enshrining in law the so-called chronically homeless. And there's a federal definition for what it means to be chronically homeless. The only difference, though, fundamentally, the main difference between someone who's living under the bridge and has been there for a really long time with serious mental health and addiction problems, and the woman who's a few months behind on her rent facing eviction, the main difference between them is time. So point being, if we don't do more to prevent homelessness on the front end, we're simply producing next year's chronically homeless population.
Okay, we have another question online. I very much appreciated your presentation, particularly your perspective on the Affordable Care Act being a jobs act. How do you handle the argument that it does not necessarily create more jobs so much as it creates more work for an already shrinking field of primary care physicians?
There are a number of provisions in the Affordable Care Act that specifically increase the number of primary care providers, not just physicians, but nurses, physician's assistants, dentists, and other I think select mental health therapists, trying to go through the whole list. The National Health Service Corps is one provision. If anyone is interested in getting paid to go to medical school or getting help with those loans, National Health Service Corps. And there are a number of other provisions, too, that provide incentives for taking some of the burdens that primary care providers already carry and shifting that to another type of workforce. We need our physicians and our clinicians, and all of our clinicians, to be working at the top of their license. And there's no reason why we need to have licensed healthcare professionals doing a lot of paperwork. So this is some of the principles behind patient-centered medical home and some of the other things where we are shifting how we do healthcare in general. So I am absolutely sympathetic to the point where all clinicians are feeling overwhelmed right now. And they're feeling like there's this tidal wave of patients that are going to be demanding care in the future. And we know that there's pent-up demand. So clearly this is a balance we need to have. But there are a number of provisions in the law that I just didn't have time to go over today that will increase the workforce, providing incentives for lower-end primary community care rather than the specialty care that we really heavily rely on in the country. And so again, I would urge people to look broadly to this because again, it is a jobs bill for bringing additional people in to help with that demand.
The questioner is very right, though, to be concerned that initially there will be insufficient capacity. So hopefully policies will shift and there will be greater capacity long term. In the short term, I think we've got a real access problem when health reform goes into effect in 2014.
I think we've seen also in some other, particularly Massachusetts, where you did initially, like Kevin said, see a spike, but then over, I think it was only a few years where you saw that come back down into equilibrium. And so I think we shouldn't be too quick to call anything a failure when we are trying to change some very intractable systems in a very short amount of time.
Good point.
Any questions from I'll continue with the online questions then. What is Baltimore doing specifically to increase non-transition housing for this population?
What are we doing to increase non-transition housing for the population? What we've been doing is primarily providing the comprehensive supportive services that keep people stably housed and off the streets. We started with a small pilot project in collaboration with the city back in 2005, where we took 30 people out of a downtown park, moved them into housing units that were paid for with housing vouchers. Provided by the city and through another federal funding source. That was expanded through a Substance Abuse and Mental Health Services Administration project to additional people. It's been expanded in some other ways. We're working to expand it now. But Healthcare for the Homeless itself does not develop or own the housing. It's all private housing and paid for through vouchers. I think we're very interested recognizing that funding for affordable housing is decreasing and shows signs that it will continue to decrease. We're interested in looking for new ways and partnerships to actually make new units available. We're not currently involved in that right now. Our long-term strategic plan over the next 5 years envisions furthering partnerships to actually produce the availability of housing that's affordable to extremely vulnerable people.
Okay, here's another question from online. I know that you spoke about the limitations of electronic medical records, but do you think that eventually that they'll help with continuity of care issues for the homeless population?
Yes, I do, but I'll qualify that by saying homeless populations, and I don't want to speak, and as if this population is singular. It's a very diverse group with very diverse needs, but on a whole, they're going to be seeking care in a lot of different places. By definition, people will be moving around where opportunities are available to them for housing or meeting other basic needs. So it's not unusual that they will receive care from 6 different hospitals, see a number of different community health centers or other providers. So yes, but it means that we have to have access to those records across venues and possibly across cities. And if I can just do a hallmark, the best medical record system in the world that I'm aware of is the VA. You can go anywhere in this country, you can go anywhere in the world on any U.S. Army base or military base, and you can have full medical records of any individual. And I just find that's the gold standard. But right now, and I'll just be honest, is we have a million different IT analysts and startup companies and tech boom that is developing EMR systems across the country, and everyone's out there with their business card trying to sell you their system. Very few of these systems are designed to easily integrate with everyone else. So then, isn't this brilliant? So then we get to hire more contractors to build bridge systems so that we can then we can connect provider A to provider D, but then we'll have someone else do it for B and C, and then we just get into this spider web of workarounds when in the end it doesn't actually unify our healthcare system. It ends up being much like the one we have now, right? A fragmented collection of programs. And so again, a single payer version of medical records would be where we need to go in order to maximize the real vision and potential behind the use of data. But certainly where we're going is a good step in the right direction. But I just wonder if we're not have 1,000 different threads of the same idea.
Is there some hope that the technology goes in that direction? I think yes, but perhaps more in the long term. There are interesting efforts in some communities in Maryland, CRISP, the Chesapeake Regional Information Exchange, looking at unifying these various systems so that providers like Healthcare for the Homeless and others can actually get real-time hospital information on when people are being admitted and when people are being discharged. There's other relationships between health centers and hospitals where they're trying to share information in a better way through their electronic systems. But the true integration, I think that the questioner envisions and that Barbara's talking about is years and years off.
Okay. Another question from online. What pilot interventions maximize the chance that those who are eligible for Medicaid but don't have it will enroll and stay enrolled?
There are a number of provisions that we know from current Medicaid experiences with predominantly kids and parents. Fast lane eligibility, presumptive eligibility. The law does give hospitals the ability to do presumptive eligibility for this population. And so if people are going to be coming into a hospital system, they'll be able to get very quickly enrolled. Obviously, the hospital is interested in getting paid, but we're also interested in connecting people to care as far as discharge goes. So we do know that there are some things we can do, and again, fast track eligibility for clearly eligible people that are considered best practices, and a number of states have adopted. And so we're hoping the improvements that I described with enrollment are actually based on what we've learned from those pilot studies over time. So I'm excited to see those go broad scale.
Can you talk a little bit about you mentioned that coming up in the legislative session, there's a bill that addresses continuity of care. Are there any other proposed legislation that will address aspects of the healthcare issues for the homeless population?
We recently just had a conversation where we're trying to understand what's ahead of us. We do anticipate that there will be a bill that's introduced that fixes some of the continuity of care aspects that we talked about earlier again, and providers needs to accept another provider's approval for treatment, making sure that continuity is there. There's fixes that we need to put into our insurance law that give insurers the ability to make those accept other people's authorizations. So we're anticipating those pieces. I imagine those are going to be very technical bills. We're fixing very minute pieces of insurance law, and this probably will not be. This is the drier aspect of policy in terms of insurance law, but very fundamental for ensuring continuity of care. I haven't seen the bill language yet, so I don't know the extent of it. And Kevin probably has some more detail.
I would just imagine that most of the health-related legislation this session will be around preparing for and fixing things for 2014. There will be some other legislation giving lawmakers the opportunity to address poverty. There will be a minimum wage bill, for example, giving Maryland the opportunity to join the 19 other states that already mandate higher minimum wages than the federal floor of $7.25 an hour. That would be a very good thing, even from a healthcare perspective. There will be a affordable rental housing bill that doesn't target down the income scale as low as we would like, but nonetheless it will mean that people in the lower and middle class that are struggling to make ends meet will have improved access to affordable housing, and that in the long run can prevent homelessness. So we think those measures are good and important.
And if I can even just add, there's two other bills that are important for us, not directly related to health care, but still very important for this population. The HOME Act, which is a bill that would prevent landlords from discriminating against your legal source of income. Right now, if I'm a landlord, I can't discriminate based on gender, religion, race, sexual orientation, or a number of other factors, but I can deny you housing based on the fact that you have a Section 8 rental voucher, the fact that you have a pension, or get your income from child support or alimony. We see that as a real barrier to obtaining housing. Kevin talked about those vouchers being very, very scarce. You have 60 to 90 days to use that voucher once you get it. You might have waited 7 years on a waiting list for it. And once you get it, no landlord will take it. And this is part of the problem in creating barriers to care. When we disinvested in public housing and we turned it over to the private sector, this is what we created. And so, again, these are the kinds of things we'd like to fix in the law. There's a piece too, ban the box. Our folks could exit homelessness if they could get a job, a decent paying job, one that had more than a minimum wage. But if you have a box on an application that says, have you ever been convicted of a crime, and you check yes, no one is going to interview you, even though you may have a master's degree and that crime might have been 20, 25 years ago. So we're advocating that we move that conversation further into the interview process so that people at least have a chance to interview and present themselves and explain their situation as a way of just getting a better fighting chance at a job. And I think that that's what we're all interested in. So again, it takes us a little bit away from healthcare, but at the same time, these are the kinds of things that stabilize our clients. And if we can get people stable in a job and housing, that has direct implications on their health.
So I can speak a little bit more to that. My name is Jen Kirshner. I'm from Baltimore Student Harm Reduction Coalition. I'm also a member of the SHARP Coalition, which is Stopping Homelessness and Reducing Poverty, to which Healthcare for the Homeless is a part. I just want to say for anyone who is interested in advocacy, there's a joint coalitions meeting this Friday, the 18th, at 4:30 p.m. at Stadium Place, and that's going to be about some of the bills we just talked about, the HOME Act, which is about source of income discrimination, the Ban the Box. There's also criminal record shielding, which would shield certain convictions from the public while still keeping records fully available to law enforcement. Some others like sick and safe leave. So there is a lot going on in this session. It's coming up very quickly. So the Ban the Box hearing is actually tomorrow in Annapolis. And February 28th is Homelessness and Reentry Lobby Day. That's going through Healthcare for the Homeless. They'll be providing buses down to Annapolis. So I'm sure on their Twitters that were put up there that information can be found.
One of the Ban the Box hearings is actually taking place right now as we speak. And the other one, as you noted, will be tomorrow. Yeah.
Here's an online question that
Momentary technical problems.
Excuse me. Here's another online question that is coming from a little bit of a different perspective. There are some people who are living long-term under an 83 overpass. Are there any people such as these who don't want assistance? And if yes, what are their rights?
We're seeing who's gonna take this one. I've been doing this work for about 20 years. Barbara's been doing this work for a very long time. Colleagues of ours around the country doing this for decades. I can honestly say that I've not met anyone as a direct clinician or now as an administrator who wants to be homeless. And I often hear questions about choice, and I think it's far more complicated than that. And there may be some underlying things happening, but when push comes to shove, if someone is offered a place to stay on their own terms, and the resources and the supports that they need to stay there, we find that we can engage almost anyone who might initially tell us that they don't want our help and that they want to stay exactly where they are. We can engage those folks into housing and off the streets. People don't want to be homeless. And we need to kind of overcome that myth out there that's existed for quite some time that there's a percentage of people who do.
And if I can add to that too, I think this is a really important point for people to understand because I think it's confusing. And I think it does lead to an inability to have an honest conversation about homelessness because what we see and hear, well, they must want to be homeless because when we offered them to go to a shelter or to this program or that program, they didn't want to go. And so, well, we wash our hands of it and say, well, there's just no helping some people. They must want this life. And I guess when we think about thinking through the details, what do we offer them when we go out and we say, hey, I got a program for you. You know what that means generally? And I mean, this is broad, but it means I'm going to put you in a place where you have to check in and out, where people will monitor your every move, where you have to be in by 8 o'clock, maybe even earlier, maybe by 6. You have to stand in line in order to get there. You have to be out by 6 a.m. You can't drink. You can't have friends visit. You can't have your girlfriend or your boyfriend visit. You can't have your wife or your husband visit. You can't have your children visit. You will have to share a room with maybe 2, but maybe 50 people, all of whom are having the same kind of crisis you're having. You will likely have most of your stuff taken from you, like stolen. And that includes prescription drugs that you need in order to maintain your health. We're replacing prescription drugs for people all the time. Or you could live under the overpass where you can sleep as long as you want. You can have a drink after a hard day. You can, there's a freedom there that we're not actually offering people. When we offer people help, what we're really doing is we're offering them what we want them to do and follow our rules. And I'll tell you, I think everyone listening to this webcast right now and here in the room, I know I go home at the end of the day and I have the freedom to have a drink. And I have the freedom to have whomever I want in my house. And I have the freedom to have my housing on my terms. And none of us would think of having someone come in and put those kinds of rules on us. It's inconceivable. But yet we're going to ask that of others, and then we wonder why they don't want it. I like sleeping in on a Saturday and a Sunday too, by the way. And so again, it's the kind of thing where why would then we hold them to a different standard than we would want ourselves? So this is the idea behind housing first. I've never met anybody who, when you went with a house key and said, I got a place for you, it's yours. You can do with it what you want. You can decorate it the way you want. You don't even have to decorate it. And you can have whatever you want in your refrigerator, and you can eat when you want, and you can eat what you want. And if you want to have friends over, that's okay too. It's your place, like regular people. You want to know what? If we could do that with everybody under the 83, there wouldn't be anybody under 83. But when we go out and we offer people under 83 the kind of homeless services that we have, it's actually a pretty logical choice to say, no thanks, I'm not interested. I know that's what I would do. And so I emphasize it because I think it's really important to understand what we're really offering people when we offer help.
We're going to have to end on that note, and actually I really appreciate that we got a chance to look at those kinds of issues also. And I really want to thank both Kevin and Barbara for doing a fantastic job in terms of number one, their work and advocacy, and number two, really presenting the public health community with important information and important things to think about, maybe a little bit differently than we've thought about before, and ways that we can expand our services and ideas about how to help this vulnerable population. So thank you very much, and I hope everybody online will tune in on February 20th. We do our rounds the third Wednesday of every month, and our topic will be gun violence prevention and the National Violent Events Reporting System. We will have the PowerPoints for this presentation posted no later than this Friday, and we will have the actual archive of the webcast up within 2 to 3 weeks. So that will be available, and we will send out a notice when the archive is available. So thank you very much.